Our last speaker for the Candida block is Theo Zaoutis, who was giving us a little heart attack because we didn't know where he was, but he did show up. Theo is professor of pediatrics and epidemiology at UPenn, where he's also the chief of the ID division at the Children's Hospital of Philadelphia. He has collaborated with the EORTC MSG groups for the definitions in pediatric patients. And he also serves as vice chair of the ID group within the Children's Oncology Network, which is the largest cancer network for pediatric patients in the country. He is the editor-in-chief of the Journal of Pediatric Infectious Disease Society, and he is also in the Red Book Committee. All of you know the Red Book defines care of pediatric patients in the US and worldwide, and we're lucky to have Theo here today.
Thank you. Good afternoon. Sorry to Pete and Luis for scaring them, showing up late today, but I'm glad I'm here with you today. I'm really, since I'm the token pediatrician today, I was just going to do a high-level overview of some of the key aspects of pediatric fungal infections. I was asked to focus on 1,000 grams, and you see there a pretty dramatic decrease in the rates of Candidemia. Has that resulted in a change in the incidence of non-albicans species? No, we've seen the same decrease in the incidence of non-albicans species, again in neonatal intensive care units nationally, and very little change seen in the groups, the birth weight groups with low incidences to begin with. One of the questions that came up regarding the decreased incidence is whether we were using central lines differently in neonatal intensive care units. Almost all low birth weight infants have central venous catheters, and whether the decrease in Candidemia was truly a decrease in catheter-related Candidemia that had to do with catheter utilization rates. And what you see here is no significant change in our central line utilization rates. So what is driving the decrease in Candidemia? Before we get to that, I'll show you some more data. This, again, published 2 years ago, a large group of neonatal intensive care units nationally. Similar kind of data. The greatest decrease in the incidence of Candidemia was seen in the less than 750 gram premature infants, followed by the slightly larger infants, and then very little change in the largest babies, which again have low incidences to begin with. So two very large cohort studies nationally that have documented at least a 50% decrease in neonatal Candidemia. The next question one can ask is this due to an increase in the use of fluconazole prophylaxis? As we know, fluconazole prophylaxis is very effective for the prevention of neonatal Candidemia. And what you see here is the use of fluconazole prophylaxis by year in birth weight. And you see by year it's significantly increased over the same time period as we see the decrease in incidence. So I think the use of fluconazole prophylaxis clearly is part of this story of decreasing Candidemia in neonatal patients. Some of the other hypotheses put forward, and thinking of the microbiome and alterations in the microbiome, as you heard earlier, here's the relationship between broad-spectrum antibacterial use by year and birth weight in the neonates. And you see here significant decreases in broad-spectrum antibacterial use, which coincide again with the years that we see a decreased incidence in Candidemia. The CDC has similar data, and Tom may show that to you later, suggesting a decreased incidence in Candidemia in children. Interestingly enough, there's a decrease in central line-associated Candidemia documented nationally by the CDC. So part of this story may be our increased focus on the prevention of catheter-related bloodstream infections. The CDC data suggests about a 50% decrease in catheter-related bloodstream infections, which is very similar to some of the decreases we're seeing in the pediatric patients. So the question one may ask is, are we preventing the catheter-related Candidemia, and what's remaining is non-catheter-related Candidemia? That's just a food for thought at this point. This is now leaving the neonatal population, but asking the question, is what is happening with the incidence in the older children, the larger children? And you see here very similar trends in the incidence of Candidemia. The black line suggests a decrease over the last 10 years. The data now are a little old. They're 2011 data. These are data from 43 of the largest children's hospitals in the United States, again showing a significant decrease. What we see here is the increase in fluconazole prophylaxis is not as dramatic as it was in the neonatal population. So that probably does not explain the decreased incidence of Candidemia in the older child. What's happened to mortality? Again, these are data from 40 children's hospitals, or 40 plus children's hospitals in the United States, and we do see a decrease in the in-hospital case fatality rate associated with Candidemia in children, a 31% decrease. Whether we're doing a better job of treatment or what are the other drivers of this decrease is not clear at this time. Continuing on with epidemiology, what about the species distribution in children? And the good news is the species distribution has stayed relatively stable over the last 20 years. About 50%, depends on which study, but if you average it out, about 50% of Candidemia in children is caused by C. albicans. About 20 to 30% is caused by C. parapsilosis, which is the opposite of what we see in the adults, where C. glabrata is the second most common organism. C. glabrata accounts for less than 10% in most studies of pediatric Candidemia. So albicans, followed by parapsilosis, make up about 80% of pediatric Candidemia. Switching gears to mold infections. These are some of the newer data here. This was published 2 years ago. This was a large prospective observational study using the International Pediatric Fungal Network, 12 US sites and 10 international sites. And what was captured in this prospective study was 131 proven or probable invasive mold infections. 75% were aspergillosis, 13% were caused by mucormycosis, and 17% by a smattering of these other rarer molds. So that's what the epidemiology of mold infections, at least in these 22 sites, looks like in pediatrics. Characteristics of these patients, I think these are pretty similar to the characteristics that we would expect. Malignancy patients, aplastic anemia patients, patients with solid tumors. The one group that I think is slightly different than what we see in adults is the patients with inherited immunodeficiencies and CGD patients and other such immunodeficiencies. What were children being treated with in these 22 centers? What was interesting is that there's tremendous variability in what was being used to treat invasive mold infections. And combination therapy, which is one of the questions that always comes up, was used in 13% of the aspergillus patients, and the combination of a triazole and polyene, which is not the combination I think that many of us think about when we think about combination therapy for aspergillosis, was used in 7% of patients. In the monotherapy group, voriconazole use was 40%. And itraconazole use was significant as well. Looking at the mucormycosis data, voriconazole was used, which we know is not active against mucormycosis. So I think a lot still to be done, I think, educationally to advance knowledge about what appropriate treatment for invasive mold infections in children may be. What happened to these kids? Here we use the EORTC criteria for outcome. And we see for aspergillosis, 25% had complete responses, 39% had partial responses, about half, or a little over half, which is very similar data, I think, to what we see in the adult patients. Again, probably reflecting the fact that the host and immune reconstitution is a significant part of success, regardless of the antifungal therapy. Just confirmatory data that corticosteroid therapy during treatment was associated with an increased risk of death. We are seeing in pediatrics a shift to rarer molds from aspergillus. These are two large acute myelogenous leukemia treatment trials through the Children's Oncology Group. And we see the documented invasive mold infections. This was AML 97, which is a protocol that ended about 10 years ago. And we see 10 of the 12 were Aspergillus. And what we see in the most recent protocol that opened in '02 and finished probably a few years ago, we see a real sort of variety of molds. And actually, there were no Aspergillus infections among these 11 mold infections in that AML protocol. This is in review right now. It's a systematic review for the risk factors for invasive fungal disease in pediatric cancer and bone marrow transplant patients. We screened 3,566 studies, and only 22 were included that met the inclusion criteria for this systematic review. And the factors associated with invasive fungal infection were prolonged neutropenia. It seems that the risk increases at some point beyond 10 days of neutropenia, but the threshold is unclear. High-dose steroid exposure, again, that was variably defined, and no clear consensus in these studies in terms of the dose or duration that made up high-dose exposure. AML therapy, acute and chronic graft-versus-host disease, and increasing age. The older children had a higher risk of developing invasive fungal disease, given the same diagnosis. So how about diagnosis? This was just published in CID. It's, again, a systematic review looking at the diagnosis of invasive fungal disease in pediatric cancer and transplant patients. The review focused on galactomannan, beta-D-glucan, and PCR methodologies. Multiple studies were screened. 25 were included, 19 focused on galactomannan, 3 focused on beta-D-glucan, and 11 focused on PCR. And I think this is an area that if we think as a group of pediatric studies, there's a lot of work to be done. All of these studies demonstrated highly variable sensitivity, specificity, and positive predictor values, and were poor when used both as screening tests and diagnostic tests. The only positive, I think, was that the galactomannan negative predictive value was high, 85 to 100% for screening, and when used for diagnosis, 70 to 100%. We hope there'll be additional data. There's 2 studies now ongoing looking at these biomarkers, one in pediatric AML patients that is enrolling 550 patients. We're up to 500 in that study, and a study through the Pediatric Fungal Network that is looking at biomarkers and combinations of biomarkers for the diagnosis. If we look at take a deeper dive into the data, we see in pediatric patients here, when used as a screening tool, the galactomannan had a sensitivity of about 68%. We see the confidence intervals here had a higher specificity. When used for diagnosis, 89% and 85% specificity. Overall, the numbers here are comparable for galactomannan to the numbers that we've seen in adult patients. Beta-D-glucan, really no, given the few studies that are out there, no ability to determine sensitivity or specificity in pediatric patients. And here's the data for adults. 2 studies using PCR, none available for screening, but for diagnosis. You see here, I would say suboptimal specificity with moderate sensitivity. If we look at the various guidelines and consensus statements for pediatric use of galactomannan, it is recommended for use in children with hematologic malignancies or undergoing transplant. One of the commonly used protocols is prospective monitoring every 3 to 4 days in children at high risk. And these are your AMLs, your relapsed AMLs, and your transplant patients. And finally, the optimal cutoff has not been well defined in children. So thinking of study questions, potentially another area. Beta-D-glucan, I mentioned, there's very little data in children. One of the studies out of Duke, Bill Steinbach's group, reported higher levels of beta-D-glucan in immunocompetent patients compared to adult patients. There's one study out of China that used an assay that's not commonly available here and had many weaknesses, but did report a sensitivity of 82% and a specificity of 82%. I personally don't have high hopes looking at the study we're conducting now that beta-D-glucan is going to be a terrific assay in children, but it's yet to be determined. I think the data are still under analysis. One positive study using beta-D-glucan is this one in neonates, where they used it to, in neonates suspected to have candidiasis. They compared 18 infected infants with 43 uninfected infants. The beta-D-glucan was higher in infected infants versus uninfected, and that was statistically significant. And they reported that a cutoff of 125 had an 84% sensitivity and a 75% specificity. I think another way to think about the beta-glucan is what they did here is they followed it after the initiation of therapy, and we see that it was a good marker. It did seem to measure a response to antifungal therapy with decreases in beta-D-glucan that coincided with initiation of antifungal therapy. So in summary for beta-D-glucan, it's been shown to be useful in adult patients. Data are too limited to make any recommendations in children, and I think that's what the EORTC MSG Pediatric group is going to suggest at this point. T2 Candida, many of you are familiar with this assay and have heard of it. This is one very, very small study in children. Almost a pilot study just published last year and presented at ASM. And it did seem to perform well, at least in these few samples. The blood culture here, a T2 result here, and there was complete concordance between the blood culture results and the T2 assays. And I think more importantly is because we have challenges in obtaining adequate volume blood samples in children. The study looked at lower volumes used compared to adults, approximately 2 mLs in children, and I think there are now more studies hopefully to be done using T2 in pediatric patients. The prevention of fungal infections in children. And let's start with the ICU setting. Luis has done some seminal work in the adult side, and many pediatric researchers in mycology have tried to identify similar prediction scores for Candidemia, specifically in the pediatric intensive care unit. This was a study out of Spain. It was a multi-center study in Spain that identified some of these risk factors here and developed a scoring system. If you had a pre-PICU stay greater than 15 days, you got a score of 3, fever at the time of PICU admission, you got a score of 2, thrombocytopenia 1, and if you were getting TPN 2. So let's go back to the score for a minute. So if you're however, I think the performance of this scoring system is suboptimal. If you had a score of 4, your sensitivity was 50% and your specificity was 81, very low positive predictive value and a pretty reasonable negative predictive value. So I think overall the negative predictive values across all these scores were pretty good, probably a reflection that very few kids actually in the PICU do get Candidemia. So what's more important in terms of determining who should get prophylaxis is that we're really not very good at it at this point in pediatric patients. This was something similar we did at our center, our pediatric intensive care unit. Here's the risk factors identified in the PICU, vancomycin use, receipt of agents that cover anaerobic organisms, therefore altering the microbiome. Again, sort of think the clinical data here support the biologic data around alterations in the microbiome. Receipt of TPN, probably reflecting, again, gut dysfunction and also alterations in the microbiome. Presence of a catheter and malignancy, all significantly associated with the development of Candidemia in the pediatric intensive care unit. After the development of a Candidemia rule, one should think about validating it in multiple centers. And we went to 6 PICUs nationally and internationally, and what we found that this is sort of complicated data, but essentially we could not validate the prediction rule. And the reason is because every PICU has a different profile, a different patient profile. Some PICUs have more malignancy patients than others. Their utilization of catheters is different. The use of parenteral nutrition is different. which antibiotics they use as their workhorse antibiotics is different. So an attempt to validate a prediction rule developed in one PICU specifically and trying to validate it in 6 other PICUs failed. So I don't have high hopes, both from the Spanish data and this US data, that we'll be able to develop a prediction rule and validate it in the near future in pediatric patients. I mentioned earlier that one area where prophylaxis has been shown to be very effective, with 2 large randomized clinical trials and multiple observational studies, all suggesting that fluconazole prophylaxis is very effective for the prevention of candidemia in neonates. This was published in JAMA now 2 years ago, which was the latest and greatest in this series of studies looking at fluconazole prophylaxis versus placebo. And really, what was interesting, the goal of this study was not to add another study to show that fluconazole was effective, but there were concerns in the pediatric community that exposure of the neonatal brain to fluconazole, for the developing neonatal brain to fluconazole for 6 weeks, may be damaging. And essentially what was found here is that fluconazole prophylaxis did prevent candidemia, and had no effect on neurodevelopmental outcomes of children, no effect on cerebral palsy, deafness, or blindness, essentially validating that it's a safe way to prevent candidemia in high-risk neonates. Looked at a number of other safety endpoints. Again, no significant differences in the fluconazole versus placebo group, including necrotizing enterocolitis, which is a condition which affects neonates, intestinal perforation, etc. What do we know about prophylaxis in older children? This is looking at induction mortality in patients who are being induced for AML therapy and the use of prophylaxis. And what we find is that the use of prophylaxis was significantly associated, about a 50% decrease in death during induction therapy. Pretty significant. This was using, again, looking at data from 40 large children's hospitals. So prophylaxis works. The next question one would ask is, what type of prophylaxis works? And the problem here is we had very small numbers. Anti-mold prophylaxis, death during induction, was 4%. Fluconazole prophylaxis was 2%. Really, the adjusted odds ratio was 0.78, but the confidence interval was huge, again, because the numbers were small, but maybe something there. Treatment and management. We have very few studies evaluating the treatment of candidemia or the treatment of aspergillosis in pediatric patients. This was a comparative effectiveness study, a real-world sort of study, that looked at these agents for the treatment of neonatal candidemia. And what was fascinating, this was very well done, a retrospective cohort study with adjustments for multiple confounding factors to the best that we can adjust in a retrospective cohort study. This was done out of Duke, the Danny Benjamin's group et al. And what was interesting is that the only product that was inferior for the treatment of neonatal candidemia was liposomal amphotericin B, lipid formulation products. Not clear why. Here it is. Has a ratio of 1.7. Lots of hypotheses around this. Do we not know how to dose this agent in children? There's a concern around the penetration of lipid formulation amphotericin B into the kidney. Do neonates have high burden of Candida in the kidney, and therefore is an ongoing source of Candida in neonatal patients? And I think the recommendations in the IDSA guidelines, the one just came out, were a little more cautious about the use of lipid amphotericin B in this population as an alternative agent. I got the 5-minute sign. Looking at, this was also a very interesting study that I want to mention, is looking at babies with candiduria and no candidemia. And what this study suggested is that the presence of Candida in the urine in neonates is just as bad as candidemia. This is no infection, candiduria, candidemia. And you see death at discharge was very similar in the candiduria and candidemia groups compared to the no proven infection groups. Death by 18 months was similar. This is neurodevelopmental outcomes. and this is death or neurodevelopmental outcomes when comparing no infection to candiduria and candidemia. So the presence of Candida in the urine of a neonate may be a marker of either undiagnosed candidemia or disseminated candidiasis. Finally, I know we all wrestle with this question of the use of catheters in patients with candidemia. There were limited data in pediatric patients. This was published by Brian Fisher at our group, looking at 436 pediatric patients with candidemia. After excluding patients who didn't have catheters, who had recurrent episodes, didn't have catheter on the day the blood culture was drawn, and did not survive at least 1 day. There was a final cohort of 285 patients, and the presence of catheter retention was significantly associated with mortality, with an odds ratio of 2.5. Complexity of care, of course, as one would expect, was also independently of catheter associated with mortality. To finish up, and I think really to make us think about the use of antifungal agents in pediatric patients, and how I really want to encourage us as a group that as new drugs are developed to think about how we use them in children and how they should be dosed. This is doses, this is voriconazole, which is a nightmare to dose in pediatric patients. Initially, I know Tom did some seminal work that showed that you needed much higher doses of voriconazole in pediatric patients. In fact, I think his original work suggested 12 milligrams per kilogram. We're pretty close to that now in the recommendations, probably around 9 to 10. This is the dose needed in less than 5-year-olds, the range to achieve a therapeutic trough level of voriconazole, from somewhere around 15 to 45. So how do I start treating a patient here? As the children get older, you see that the range, the dosing range that's required to obtain therapeutic plasma levels gets narrower. Why is it important? It's because even in pediatric patients, there's a relationship between voriconazole trough therapeutic plasma levels and outcome. Bad outcome is the triangles, favorable outcome is the circles. Voriconazole trough levels, many more triangles down here. This was significant finding that unfavorable outcome was related to suboptimal voriconazole trough levels. So challenging to dose, and we know it's important to dose because the outcomes seem to be related to these trough levels. So to wrap up, the incidence of candidemia in pediatrics seems to be decreasing in the United States. I don't know if Tom has any more recent data. The species distribution is relatively stable. I think we need a little more information on what's happening in the epidemiology of mold infections. Is this shift to non-aspergillus mold being seen across more pediatric patients? Prophylaxis, the challenge continues, and I think it's probably even more challenging in children. Which patients? We are beginning to develop data around diagnostic testing, but again, I encourage us to think about additional studies around the assays that we are using every day in adults. Is the mortality decreasing as we see in some of the data? And I think the challenges around optimal treatment continue. Thank you.